Hello, everyone, and welcome to today's session. My name is Chanel Blackwood, and I am the marketing manager at IHEA. Welcome and thank you for registering for today's workshop, Prioritizing Genomic Medicine, Reflections on the Role of Health Economics for Changing Policy and Clinical Practice. Today's session will run for approximately 2 hours and will be recorded and uploaded to the IHEA website afterwards. Before we get started today, I just wanted to run through a couple of housekeeping items. If you experience any technical difficulties throughout the duration of today's session, please feel free to type them into the chat box at the bottom of your screen, and I'd be happy to assist. Everyone on the line has been muted except for our speakers in an effort to eliminate background noise. We encourage you to turn on your cameras to allow for the session to be interactive. If you would like to speak aloud, feel free to use the raise your hand function and unmute yourself. We'll be holding some of the questions until the first portion of the session has concluded, when they'll be opening for a facilitated Q&A. I'll now pass things over to Dee Dee. Dee Dee, over to you.
Wonderful. Thanks so much. And thank you everyone for joining us today. Just going to share my screen and hopefully it is all working well. Thumbs up, pretty good. All right, awesome. Well, I'm Dee Dee Wyman, and on behalf of my fellow conveners, I am really excited to welcome you to our very first annual symposium. This symposium has been organized by our IHEA Special Interest Group, which really focuses on the economics of genomics and precision medicine, and we call ourselves the Economics SIG. We're really excited to be joined today by so many international researchers who are interested in this area, and we really look forward to collaborating with all of you moving forward. Before we get started, just want to take a quick moment to say a big thank you to all of my SIG conveners, as well as thank you to the IHEA communications team who have helped to make this event possible. So here you can see today's program. We're going to start with a brief introduction, followed by a 75-minute international panel discussion on the role of health economics for changing policy and changing clinical practice. We have some amazing panelists joining us today who have expertise that spans academic research, clinical and policy translation, and also industry perspectives. We'll then take a quick 5-minute refreshment break and come back together for a 45-minute workshop that's centered on engaging with early career researchers and researchers in low and middle income countries who can work together to help us shape future SIG activities. Before we talk specifically about today's event and the symposium series more broadly, I'd just like to remind everyone why we're here today. Just over a year ago, we started the IHEA Special Interest Group, SIG, focusing on the economics of genomics and precision medicine. And we had some somewhat lofty aims. We wanted to connect researchers around the world who were really interested in the application of health economics to the areas of genomics and precision medicine. We wanted to provide platforms for generating ideas through dialogue and academic inquiry. We wanted to help foster collaborations on ongoing and future research and help our SIG members to broadly disseminate their work. We also wanted to support research in low and middle income countries and research conducted by early career researchers to support capacity building. And ultimately, we wanted to build a global network of health economists who were interested in working together to inform the allocation of resources to genomics and precision medicine around the world. Our SIG is currently led by, sorry, I'm having some PowerPoint issues with showing images, so hopefully you can see everyone's photos now. Our SIG is led by 10 conveners at the moment who are each responsible for different areas that are needed to help us achieve these objectives. Our conveners have collectively worked together to organize today's event. And at the moment, we actually have a couple vacancies. So we have a convener vacancy related to communications and networking, and another related to organizing conference sessions. So if anyone in attendance today is interested in volunteering for either of those roles, please do send us an expression of interest over email to the email address shown below on the slide, ihiagenomics@gmail.com. Our annual symposium series is meant to help us achieve our SIG objectives. We want to connect SIG members and non-members who have a shared interest in understanding the value of genomic medicine and helping to inform its adoption. We want these symposiums to provide a platform for generating discussion and promoting collaboration across disciplines, across jurisdictions, with an emphasis on ensuring diversity and highlighting research conducted by early career researchers and those working in low and middle income country settings. Our symposiums will be rotating around time zones every year to help provide equal opportunities for participation. And when these symposiums are virtual, they will be recorded, as you'll have noticed today. And those recordings will be made available online so that anyone who was not able to attend, perhaps because they were in a different time zone, they'll be able to tune in later. The focus of today's symposium is on the topic of prioritizing genomic medicine, reflections on the role of health economics for changing policy and for changing clinical practice. To preface this topic, let's consider why health economic evidence might be needed to inform the prioritization of genomic medicine. We know that investment in genomic medicine is increasing steadily, and governments around the world are committing millions, even billions of dollars towards genomic research. This research is really designed to generate a breadth of genomic data that will help to drive discovery, drive research, and ultimately improve patient care. But the evidence base informing its implementation is really limited for a number of reasons. Often genomic medicine focuses on small patient populations, perhaps because the patient populations who are eligible for genomic medicine who might benefit from genomic medicine are quite small. We're also faced with evaluating technologies whose costs and whose uses are changing really rapidly. Often genomic research is conducted outside of a traditional randomized controlled trial design, which can make it really hard for us to understand the comparative effects and the comparative value of genomic medicine when we don't have a randomized counterfactual. Often these genomic research studies are also focused on short-term endpoints. So there's a lot of uncertainty around the downstream impacts of genomics and precision medicine for patients and for healthcare systems. The health economics voice is really critical to help generate evidence on comparative effectiveness, cost effectiveness, and value to help inform the appropriate, equitable, and efficient adoption of precision medicine. Our SIG really wants to help ensure that our global community of health economists is well equipped to tackle these evidentiary challenges now and going forward into the future. Today's workshop is going to focus on improving how we work together to make sure that this health economics voice can be heard by decision makers internationally. We're going to discuss a few specific topics that are shown here on the slide. And in particular, we're going to discuss what future high-value SIG activities we can undertake and help plan to support research collaborations and support capacity building when conducting health economic evaluations for genomic medicine. The workshop is also going to represent a networking opportunity for all attendees, so we do hope that you hop back on the line and join us following the panel. Today's panel is bringing together experts who have industry, academic, and some decision-making experience. These panelists are joining us from China and from North America. We have unfortunately had one panelist who is unable to attend today. Our panelist from Sydney, Australia, Sarah Norris, has regrettably sent her unavailability today. We are still very excited that we have 3 panelists who are getting together to discuss their experiences when generating and using health economic evidence to help change and shape policy and practice. Our first panelist, Dr. Li Yang, is an associate professor of health economics at the School of Public Health at Peking University in Beijing, China. Lee's research uses microsimulation to assess the cost effectiveness of public health strategies, like the use of genetic screening for patients in China, and to provide evidence for precision prevention. Our second panelist, Dr. Brock Schroeder, is Vice President of Market Access at Illumina. Brock leads efforts to generate evidence on the clinical and economic utility of genomic testing to support engagement with payers and with HTA organizations. Just noticed that we might be missing one photo, so there we go. Hopefully it's showing now. Our final panelist, Dr. Scott Gross, is an economist with the Centers for Disease Control and Prevention, also known as the CDC in the United States. And he's particularly interested in the intersection between genomics and public health. His work informs the health outcomes and the economic benefits of public health strategies using genomic technologies, particularly those related to congenital and neurodevelopmental conditions, along with other clinical contexts. So with that, I will pass things over to James Buchanan, who's going to be chairing today's panel discussion. So I'll just stop sharing.
Thank you very much, Dee Dee. Thank you for that introduction. A welcome from me as well to today's symposium and this panel discussion. Great to see we've got so many people already. I can see looking at the participants, we've got a wide variety of people from all over the world. So that's great to see. So just before we kick things off, a couple of practical points. We're going to run the panel discussion for about an hour. It might be slightly less, it might be slightly more, but we'll aim for about an hour. We'll see where the conversation takes us. What we'll do is we'll ask you to save your questions for the end. We're going to put aside 15 to 20 minutes at the end, when hopefully there'll be more than enough time for you to ask any questions that you have to the panelists, and we can see what directions the conversation takes then. You can, by all means, ask questions in the chat when we get to that point of the discussion, but what we prefer, if you're comfortable doing so, is to put yourselves on screen and ask the questions directly. We are recording, so if you don't feel comfortable doing that, then by all means put your questions in the chat. But we've all spent a lot of time on Zoom over the past couple of years, and it just makes things a bit more interactive if we're all on screen. So if you can do that, that will be fantastic. I think, as Dee Dee says, we'll stop at about 25 past 7, I think, Eastern time, in about an hour and 10 minutes, whatever hour it is with you. We'll have a little break, and then we'll come back for the workshop after that. That's it on the practical side. So I think we'll get right into the conversation. So we have Scott, we have Liang, we have Brock. I want to start by asking them all to say a little bit about the context within which they work as health economists. So the question we have to kick things off is, what role does health economic evidence play in your decision in your jurisdiction, related to genomic medicine? And that's in informing clinical decision making, regulatory decision making, and reimbursement decision making. So what role does health economic evidence play in all those contexts related to genomic medicine? I'm going to pick on Scott to kick us off, if you'd like to unmute, Scott.
Okay. Well, the United States is famously a country where economic evaluation does not directly inform public policy or most clinical practice decisions. There are some exceptions, but that's just a generalization. But that doesn't mean that health economic studies do not inform decisions, but it's done more indirectly behind the scenes. I see Brock nodding his head because Brock can speak to that much more directly. Also, I know Catherine Phillips is on call, and she also has tremendous expertise in how payer decisions relate to the economic evidence in the area of genomic medicine. I work in public health, and so there are some areas of overlap between genomic medicine and public health. But our focus is really more on early detection and prevention, rather than on advanced diagnostics and advanced therapeutics. And I think the economic evaluation may be more specifically useful to decision makers when something is immediately medically actionable for the advanced diagnostics and advanced therapeutics. So I will stop there.
Thanks very much, Scott. I mean, before I turn to someone else, yeah, we are, I think, all aware that the use of economic evaluation evidence is not the same, shall we say, in the US as in other countries. But behind the scenes, there are surely conversations that happen. Can you reveal anything based on your experience as to how indirectly this evidence might?
Well, I'm not privy to the behind the scenes discussions in those areas. The one area of policy that I am involved with is the newborn screening policy. Mm-hmm. The United States has an advisory committee on heritable disorders in newborns and children that makes recommendations to the Secretary of Health and Human Services for adding disorders to a recommended uniform screening panel that the states are encouraged to consider following. It's not a mandate. The advisory committee, I'm not a member of the advisory committee, but I'm involved with preparing evidence that is submitted to the committee for their consideration for disorders that have been nominated. Cost effectiveness is not a criterion that is considered. If there are economic evaluation studies that have been conducted, they are certainly considered in that process. But in our experience, that almost never happens because a disorder is nominated based on early evidence of clinical effectiveness. And so it's very much dependent upon both having a screening test and assay that has been demonstrated to work in a high throughput public health setting, and the availability of treatments, life-altering treatments that can substantially improve outcomes. And by the time that the economic analysis is done, there's typically the decision's already been made. But we certainly look at information that is available, and we do decision modeling, not with the economics, but trying to look at what is the expected outcomes with standard of care versus with the early detection following newborn screening. And so we could try to consider risks and benefits rather than a cost utility analysis.
Okay, thanks very much, Scott. I'm going to go to Li Yang next, if you can unmute. Same question, really. What role does health economic evidence play in your jurisdiction related to genetic and genomic medicine?
I think health economic evidence is mainly used in the reimbursement decision-making of innovative drugs in China. And the economic evaluation report submitted by the pharmaceutical company for national pricing negotiation since 2017. Therefore, the health economic evidence related to genomic medicine is mainly used when the lower drug is suitable for patients with a specific gene mutation, such as BRCA for breast cancer, EGFR for lung cancer. Since 2017, many new gene therapeutic drugs have been included in the national reimbursement list through national price negotiation, such as DAD, direct acting antivirals for HCV patients, immune checkpoint inhibitor PD-1 or PD-L1 for lung cancer, and information from genetic testing can be used before prescription of those drugs.
Okay, so the context is obviously a little different to the US in terms of the acceptability of economic evidence. Is that evidence generally accepted by all stakeholders in the process? Are there any that sort of push back a little on the use of economic evidence, or is it generally agreed that it's an important part of the process?
Yes. So since 2018, all the pharmaceutical companies, if they want their drugs for being included in the national insurance drug list, they have to submit the economic evidence about their drugs, and we have the we have the economic professors or from the academics. They will the government will let us review the reports and give some comments for the price about the national price negotiation.
Okay, thank you very much, Liang. Brock, I'll turn to you and ask the same question. And I know you and Scott are in the same country, but I would guess that you probably have different conversations with different people about health economic evidence. And I don't know if your experience would be the same.
Sure. Yeah, and our group engages with different stakeholders around the globe, so I can speak a little bit to that as well. I certainly agree with what Scott said about the U.S. Certainly no role in regulatory, little official role in reimbursement. With Medicare in particular, which many of you or all of you may know, but in the U.S. it's the main public payer for patients over the age of 65 primarily. They're not even really allowed by law to consider cost when making coverage decisions, right? So it's not even just that it's not official, it's not allowed. I would say, on the commercial insurer side, so then if we're talking about patients under the age of 65 that have insurance either through their employer or through what we call the individual market, most commercial payers, there's a little bit of a mix, but there's well over 200 individual commercial payers in the US. Many of them won't accept health economic data similarly. Some of them will consider it. It's not a primary determinant, I would say, of coverage, but maybe it's that sort of behind the scenes that Scott referred to. But we'll have some medical directors that will tell us explicitly, do not send me any cost effectiveness data. I will not look at it. I will only look at clinical data, which is hard to imagine, but they won't. And others who will say, sure, send it to me. It won't be the primary part of my consideration, but we'll consider it. I think the behind the scenes part can come into play when there's often these silos of decision making in particular within commercial payers, where there will be a coverage decision whether or not a particular test or technology should be covered as part of the plan, and then separately there's a contracting silo within the payer that will try to negotiate a rate, and those can be very distinct discussions. So there can be an opportunity to have an economic discussion, if you will, but it's certainly not the way you would think about it in terms of a typical HTA type evaluation outside of the US.
Sure.
I would say that in the US, things are probably starting to change a little bit and opening up. We have groups like ICER that are now interacting at least at the pharmaceutical level. Commercial payers in particular are looking at those to help make decisions. So it's coming into play, but it's slow, I would say, compared to your traditional HTA type markets. Outside the US, we certainly see more emphasis on health economics, although I would say it can still vary quite widely when it comes to genomics. Now, if you're talking about genomic medicine, of course, where pharmaceuticals get involved, it becomes more traditional. But when it's just in terms of testing itself, we see a lot of variability. Some markets that have, something resembling, an HTA type process, or HTAs that have, whether it's MSAC in Australia or ICVIG or UNETA that have actually considered genomic tests. We have some of that, although I would say, again, it does vary widely. In many cases, we're still having primarily a clinical discussion, and then maybe there's a just, really budget impact or even just micro costing, right? What if we agree that this should be covered? How much does it cost? What, and therefore how much, should we put into the budget envelope for this? So I would say it's still quite a bit different, right, than the way we think about health economic evaluation of pharmaceuticals.
Mm-hmm.
I think in the US, coming back to the US really quickly, on the clinical side, and Scott hinted at this a little bit too, we're starting to see some of this where maybe academic centers are putting their foot down, so to speak, about some pharmaceuticals, or at least trying to do their own evaluations of whether they think something is cost effective, and then not, agreeing as an academic center that they would not prescribe it. But again, that's, I would say, probably few and far between, but we have seen some of that happening.
Okay, thank you. That's a fantastic answer. Thanks, Brock. If I can add sort of one supplementary question to you, I guess, specifically. We've asked about this sort of clinical and regulatory and reimbursement decision-making context. Commercially, I guess for yourselves as representatives of that side of things, what role does health economic evidence play internally? Is it something that features only very late on in the decision-making process, or is there sort of very early economic modeling happening to kind of guide decision-making, go, no-go decisions?
Internally within the company.
Yeah.
It's a fantastic question. I can primarily speak to where I am now at Illumina, in that, and I've been at Illumina for a little over 5 years now. I would say in that 5 years, Illumina has become more of a clinical company, right? We were maybe primarily a research tools company for many years. And then as next generation sequencing started to be used more in the clinic, the company is now moved in that direction more and is producing IVD, equipment, IVD sequencers, IVD kits, et cetera. So that, by nature forces us to become more clinical. So I think at the beginning of, setting up market access and health economics and outcomes research function at Illumina, there wasn't a lot of understanding of cost of typical health economics. Even the term cost effectiveness, people would use that term, but what they really meant was, will labs find this to be a cost efficient approach, as opposed to, cost effectiveness the way that folks on this call would think about it. So over time, I think we've tried to certainly educate, and exactly what you're saying is move some of that discussion upstream, and so that we can actually use the capabilities we've developed in our health economics and outcomes research team to inform some of those decisions earlier, so that we can, actually feed into the, sort of strategic process within the company to say, we think, this is what we think ultimately will face this application of genomics. Oftentimes that's still clinical, right? It's more on the sort of decision modeling side of things, but certainly we will also bring in a health economic aspect there as well. What do we anticipate payers in the US or globally will think about an application like this? What would be the budget impact, et cetera? So we will try to bring some of those things earlier in the discussion to help understand, as well as, what you might expect. What is the current standard of care? How does the new genomic approach compare to that? How would payers ultimately think about that? At the same time, realizing that payers are still trying to figure this out, right? So we're guessing a little bit in terms of what that analysis will look like on the back end. Okay,
that's really interesting to know. We could, of course, do a whole call on misinterpretations of what cost effectiveness actually means, but I think we've got more interesting things to discuss today. But interesting that you see that internally, as well as we see the sort of standard conclusions in papers that something is cost effective without any economic evidence being in the paper at all. So that's a constant source of frustration. Okay, so I think that set the context a little bit for the three panelists we have today. So to sort of dive into the detail a little bit more, I wanted to ask about the main challenges that you faced when generating or when using health economic evidence to hopefully inform policy and clinical practice in this context. And I'd like to start with Li Yang for this question. So what are the challenges that you faced as a health economist when generating or using health economic evidence to inform policy or clinical practice?
Well, I think besides the challenges raised by Dendro, such as limited patient numbers, rapid changing technology cost, non-traditional travel design, the trial often single arm and not based in China, come from other countries and only short-term outcome data. There are also some other challenges in China, I think. First, the price of genetic testing are different from among different companies. Take the genetic testing for breast cancer as an example. The price could vary from $20 to $700. As I know, it's only 20 pounds in the UK, and the cost of genetic testing is often not covered by the insurance scheme. Secondly, I think the currency of the genetic testing also varies among different companies, and it will affect its application for treatment choice. Thirdly, I think the acceptability of genetic testing in patients is rather low in China. I have ever discussed it with the clinical doctor from National Cancer Center. Only less than 10% of patients with breast cancer would like to get genetic testing. It's rather low. Then when we conduct the cost effectiveness modeling, we are faced with limited data and the lack of the appropriate comparator. So all above will affect the robust of the modeling results. I will stop here.
Thank you, Leanne. And do you know what is driving the lack of acceptability in China? Is that something that there has been much research into?
Could you please repeat again?
Sure. So you said that the general acceptability of genetic and genomic testing is quite limited in China. Do you know what is the cause of that? Do you know what is driving that in China?
As I know, in China, the genetic testing are often driven by a commercial company, and only some of could be provided by the hospitals. So because those kind of service are not included in the national insurance scheme, so I think maybe the regulatory of those kind of service is very limited.
Okay, thank you, Leanne. Brock, I'll go to you next on that question. So what are the key challenges that you come across related to health outcome evidence?
Yeah, I think about it in a couple ways when you ask the question. You know, one is maybe around the challenges with generating evidence, and you know, Dee had some of those in the upfront slides, you know, in terms of things like small patient numbers, and you know, especially when we're thinking about rare conditions. I think about a lot of the data that's developed around genomics usually has short-term endpoints and not long-term follow-up. You know, some of the aspects of the impact of genetic testing, like cascade testing on family members, may not be captured sufficiently, right? I mean, a lot of these things are captured very well in the literature as challenges. So I think there's kind of challenges generating evidence in the first place that is maybe at the same level as we'd like to see. I think the other area that we see as a challenge that I know you do as well is the real world data resources, you know, which are so valuable for clinical and economic data generation, are really not adequate for genomics most of the time, right? In many cases, we can't tell what was done, even what type of test was done, much less what the test result was and what the impact of that test result, which is ultimately we want to see all of those things, right? And linking these data sets, as you know well, can take years and be quite a challenge, right? And so I think, you know, those are those are key things that I think prevent us from generating data in the first place that we'd like to at the scale we'd like to. I find that the, how we use these, right? How do we put these data in front of payers, in front of stakeholders, and try to make an argument about it? Maybe I'll start again in the US and then say a little bit about OUS, but in the US, as I said earlier, many commercial payers won't review health economic data at all. If they do, they're very much focused on short-term budget impact. In the US, there's this churn between payers of 2 to 2.5 years. And so if you have something that you think, and Scott could certainly speak to this more, if it's more of a screening type approach or something that might capture value over 5 or 10 years or a lifetime, it's very challenging to make that kind of argument to a commercial payer in the US that just doesn't have an interest in, they might in theory have that interest, but they don't really have that interest in investing in something that will ultimately reap benefit for somebody else. So that's been a challenge. And it's kind of related as well to that siloed thinking between, what's clinical evidence over here and what's the budget impact over there. We also see some of that thinking even in terms of how diagnostics and therapeutics are related, right? So we get a lot of discussion amongst the community in the US about the cost of genetics going up over time. They see many more genetic tests on the market, it's increasing in spend. And so there's a lot of focus on that, but not necessarily a focus either positive or negative on what's the impact of that spending downstream, right? You can certainly imagine examples where the use of a test could lead to a decrease in, the use of certain therapies, chemotherapy in the case of something like an Oncotype DX, or a non-invasive test like Cologuard that could have an impact. So there's those sorts of things, but they aren't necessarily even being considered in the appropriate way, in a true analysis. So that's some of the challenges using data inside in the US. Outside of the US, the one that I was thinking about when you brought up the question was, we struggle a little bit in the oncology field in thinking about how countries are thinking about the use of companion diagnostics for pharmaceutical therapies, right? Where it's often the pharmaceutical company it is the pharmaceutical company that's making the submission with their drug, which is, approved for patients with a positive biomarker. In some markets, the diagnostic test isn't even required to be part of the economic analysis. In the markets where it is, there's often, a pharmaceutical company will maybe put a single gene test in there, right? A relatively inexpensive single gene test, which is not really how it's being, how genomics or the diagnostic approach is being captured, right? And so there's this element that I think this, again, dissociation between the decision making around pharmaceuticals and how diagnostics are actually being practiced that creates a bit of a challenge. And in most cases, the diagnostic manufacturers, whether that's a company like Illumina or a laboratory, are not really at the table, to be part of those discussions. So that's a challenge as well. I think the operational considerations that come into play, the laboratory workflow, the efficiency, the maintenance of different tests, the validation costs that laboratories need to consider are completely absent from those discussions, right? It's just, a single price of a test that will probably never be used, right?
Yeah. That's fascinating. It's and frustrating in the same breath that we have these sort of roadblocks. Scott, from your perspective, what are the obstacles that you come across related to the use of health economic evidence?
Obstacles and opportunities are flip side of each other.
Sure.
I'd like to give one specific case study. Newborn screening for severe combined immunodeficiency, or SCID, S-C-I-D. It's a primary immune deficiency disorder, which all states in the United States now screen for using a molecular genetic test. Before SCID was recommended in 2010, all newborn screening tests were biochemical. So this is for states to start screening using for SCID required adding molecular testing capacity and expertise in these public health laboratories, which was quite a paradigm shift for public health newborn screening. Back in November 2001, CDC convened a meeting in Atlanta with a private foundation focused on primary immune deficiency. and where we heard the latest evidence about the clinical treatment, the effectiveness of hematopoietic stem cell transplant, which was much more effective if done within the first 3 months of life, shown using, or some infants were detected due to family history and others were not, is both cheaper and much more effective. And researchers from National Institutes of Health presented breaking evidence about the development of a new assay, which years later was approved. And so I sat there with my little laptop and said, okay, what if the cost is $5 for this test? The disorder is 1 in 100,000, turns out to be about 1 in 60,000. And the reduction in costs is so much, and the reduction in mortality is so much. Would this be cost effective? And I said, yes, it would be cost effective if these assumptions pan out as we thought. And subsequently, there was more prospective cost effectiveness analyses, which reached very similar conclusions. And then after the disorder states started screening, we worked with Association of Public Health Laboratories and a private company to do a cost effectiveness analysis, and also with the State Health Department in Washington. This Washington State actually requires economic evaluations before they add a disorder to their screening panel. And so John Thompson and colleagues had created a spreadsheet model, simple spreadsheet model, cost benefit, 10-year time horizon for that. They had done their microcosting study of how much it costs to implement screening for SCID in their state. So we piggybacked on their model and produced estimates. And we also made that spreadsheet model available. And so people in other, like in the Netherlands, use that model to help inform the development of a more sophisticated model, which they then published. But basically, the results have been very consistent all along. In the most recent publications, Ilias is on this call. He and his group just published a cost effectiveness analysis of newborn screening for SCID in Australia. And so I think that is even though there have been challenges by identifying the cost and the effectiveness, especially long-term outcomes, we had no idea what the long-term life expectancy would be or long-term treatment costs. But the evidence was so compelling based on short-term costs and outcomes within the first 2 years of life that I think that became very compelling for why it was important to add screening for SCID.
Well, thank you, Scott. I mean, that has partially addressed the next question I was going to ask as well, and I'll ask that in a second. I guess interesting to note in the context of what Brock said about you know, the short-term thinking that you were able to inform a decision based on a model that had a 10-year time horizon. I don't know if that is specific to Washington State that's permitted, or maybe they had a little more forward thinking. But yeah, interesting nonetheless. So what I wanted to ask next actually builds on that, which was I wanted to ask the panelists to share any success stories that they have where health economic evidence has really been critical to informing implementation of a genomic test or coverage decisions. I think, Scott, you're off the hook for this one. You've answered that question already. So I might go to Li Yang first, Li Yang, and ask if you can share any success stories where health economic evidence has really, you know, directly contributed to test coverage. I think you're still muted, Li Yang.
I think in China since 2019, several drugs, new gene therapeutic drugs have been included in the National Insurance Drug List through national price negotiation, such as direct-acting antivirals for HCV patients. More DAAs were included in 2020 and 2022 for a wide range of treatment options. And and reimbursement restriction were optimized further. The price is the lowest in the world, as I know. So it will speed up the eradication of the HCV in China. We have used the Markov model and threshold analysis to compare the calculated price based on CA modeling and the actually price reduction of DAS. We found the calculated price is far lower than its actually price. So besides the evaluation, economic evaluation evidence, I think other factors included the budget impact, international reference prices, and disease market characters also provide evidence for negotiation. And the players willing to pay plays the decisive, plays the main role in the national price negotiation.
Okay, thank you. So if I can just pick up on one thing you said there, actually, and actually in a different answer as well. Is it correct to conclude that the main impact you have as a health economist in China is on the cost side of the equation, if you like? So how does evidence on value feed into decision making? What is the outcome measure that is used in the context of genomics to drive decision making?
I think the economic evidence only provide some evidence for the decision making. Other factors such as the cost, the international reference price, and budget impact analysis is also important for the decision making. I think the cost may be the main driver.
Okay. So when you build your Markov models there for genomic test evaluations, do you stop at cost per diagnosis, or do you go beyond that normally?
Yes, we will put all the cost in the modeling.
Okay. Okay. Scott, was that?
Yes. There is, I think that a case where the health economics has informed decisions, but it's really the clinical utility, which is the primary, is the large number of studies produced in recent years evaluating the application of rapid whole genome sequencing in the chronically ill infants, NICU and PICU. Multiple studies have demonstrated that there's significantly better outcomes with rapid testing, and studies have often reported cost savings. But I think it's really the dramatic evidence of improved outcomes, which has really led to a rapid shift in sentiment among payers and providers in support of that application. I think Brock, but that's actually a lead into Brock, because this is Brock's area of expertise.
Yeah, I mean, we don't need me in this conversation, clearly. Brock, what else can,
I can pick up from there,
add to that?
Yeah, I was gonna give two examples, and that area of pediatric patients with rare diseases was one of them. I think there's been this host of evidence from a lot of it from the group at Rady Children's Hospital, which is here in San Diego, where I am, but several other groups as well that have done the studies. And then there's been some, health economic analyses along with those studies, as well as some models that have been, produced and published otherwise that have highlighted this, that particular maybe subpopulation of critically ill infants, in the NICU PICU setting, and that, there's both a clinical benefit, as Scott said, and the potential for pretty significant cost savings from a number of different reasons. I would say even more broadly, we've done some work, and but I was going to point to the example from Australia in particular around, and there it was primarily whole exome sequencing that was driving that. There were a number of these studies from the group at Murdoch Children's Hospital and the University of Melbourne focused on the application of whole exome sequencing for pediatric patients with undiagnosed, potentially genetic diseases. So these are typically developmental disorders, intellectual disability, congenital anomalies. And a series of studies that were done there that looked at patients that had been on a diagnostic odyssey, were diagnosed with whole exome sequencing, and then looking back in the patient's records to understand what might have changed for those patients had they been diagnosed earlier, which is these are challenging patient populations, as we talked about earlier, to do these kinds of studies. So that's one approach, and they identified both the opportunity to consolidate genetic testing, right? So instead of doing test after test after test over years, you could do one test at the beginning. But as well as that was really only represented, if I'm remembering, maybe 20 or 30% of the cost that could be saved, because you're also saving costs from specialist visits and imaging and anesthesia from MRIs and pathology, et cetera. So there was an opportunity to not only have better effectiveness, as Scott said, in terms of the number of diagnoses, the proportion of patients diagnosed, but also have significant cost offsets such that it could even potentially be cost saving. And that led, that work was part of the submission to MSAC in Australia that led to a positive HTA review, I think maybe 3 or 4 years ago now for both exome and genome sequencing. So I think that's one example where that was actually health economic evidence that for a genetic test that went through an HTA. There's not very many that you can go from end to end there. So that was one. We had another example in the US. So we were interested in looking at non-invasive prenatal testing. So that's prenatal, screening for trisomies. And non-invasive prenatal testing has been used for probably 10 or 12 years now. But it was primarily used in the US at the time for women over the age of 35, pregnant women over the age of 35 that had a higher risk of trisomies. There were some payers that were starting to pay for what we would call average risk pregnancies, or under the age of 35, but a number of payers weren't paying for that. So we went about engaging in a risk sharing type agreement with a payer in the New England area, Harvard Pilgrim, where they opened coverage for average risk. We shared, as Illumina, we shared the risk with them, but we agreed that we would basically work with an academic collaborator and look at the real world evidence of what happened following that change in coverage policy, what happened in terms of utilization of the testing, change in budget impact, and at least for the period of coverage, we were sharing that with them. So we did the project, we published the results, there was a budget impact model associated with it. And what I think was the nice example is after that was published, we not only were able to show that with that payer, which was fine, they were happy with it, they kept the coverage open, which that alone was nice, but we've been able to actually use that model with state Medicaid programs. So in the US, Medicaid covers low income in each state. They're state by state programs, so they're partially funded by the federal government, partially funded by the US, or by the states. But many of those state programs, they're interested, kind of coming back to the discussion earlier about whether payers in the US are interested. I would say state Medicaid programs, not as interested in cost effectiveness, but definitely interested in budget impact because they're highly cost constrained. And so things, in many cases, have to be cost neutral because there's just not extra funds to pay for things. So we were able to use that model to basically help them understand, if they change their coverage policies, what was likely to happen in the real world based on what we saw with another payer. And we were able to, basically connect those programs with the academic collaborator to have those discussions, which led to a number of states being willing to open their coverage policies and cover all women and not just women over the age of 35.
Fantastic. It's two great examples. In particular, the first one I find interesting because it's an example of where the evidence that we can produce as health economists has potentially a lot of value, but it's also the area where it's most difficult to do the work in some respects, in terms of bringing together big data sets and trying to answer a question where you don't necessarily have the granularity within the data set to get to the answer you want to get to. So yeah, speaks to the sort of complexities we encounter when trying to do this work. I had a bunch of questions I wanted to ask about, what evidence we need, what are the key methodological challenges, and I think I might leave those to the audience to ask at the end if they're interested, because I want to skip along to some potentially juicier questions that we had. And in particular, thinking more broadly about how we as health economists interact with decision makers, whether it's clinical decision makers, policy makers, health technology assessment agencies. How can we support them better to use health economic evidence to inform decisions about genomic medicine and genomic testing based on your experiences? I'll start with Scott on this one, if I can, Scott.
Well, I don't think I really am qualified to answer that question. We don't have an HTA in the United States. I noticed that Olga from Ontario is on the call. Perhaps she could unmute herself and answer that question in my place if she's willing.
Well, that puts Olga on the spot, but she's unmuted.
Hello, it's really nice to meet you all, and especially Scott, Dr. Scott. Yes, we do in Ontario. We do have an advisory committee. This is a genetics advisory committee, and we do produce HTAs that consider clinical evidence and economic evidence for genetic conditions and for other conditions. But we have a specific committee that makes decisions based on the consideration of clinical and health economic and patient preference evidence. And I can put website for where we publish our reports for your information. So you could look at the reports and how the evidence is, what kind of evidence we produce, and then how recommendations are made. But we do interact with clinic in the process of making this economic evaluation. We decide whether we should go for modeling and full economic evaluation, or whether we can just do budget impact because there's not enough clinical evidence to do it, or there is enough evidence already published, so we just can conclude from published evidence that something is not cost effective or cost effective. Most of the time, we really do primary economic evaluation, and which is done together with clinicians. We have experts and we have reviewers, and Dr. Gross was serving as one of my reviewers for one of my HTAs for fetal genotyping. That's how we met. We are very grateful for his expertise. But I got surprised here because I didn't really know that you don't really do a lot of HTAs to support decision making in states. So that was my surprise.
Okay.
I'm not sure if I'm answering the question, but maybe if I share this website where you could then, like, the group can take a look and see what kind of evidence we publish.
Please do. Please put it in the chat. And maybe just one quick follow-up question. Just what is the general, how to phrase this, sort of the health economics literacy of the decision makers related to, and this isn't just general health economics literacy, but also related to the specific challenges that we face in the context of genomics. Is there an awareness of how difficult it is to do this work?
It is really difficult, and we do train, like we have a committee, and we train the committee to understand what are the challenges of the cost effectiveness analysis, and what's the meaning of ICER, what is the controversies around calculating qualis in these areas. We are really lucky to have the chair of OGAC, that's Ontario Genetics Advisory Committee. This is Dr. Wendy Unger, and she could sit on this symposium really, like she would be able to explain the whole decision making if you invite her in the next sessions, I don't know. But it is hard to understand, but they do understand, and they're actually interested because these tests if they're given to a large number of people, they are costly. But if there are savings in terms of treatment costs, then they would pay attention. So it is matter of education, and if there is, we as an agency, it's our duty basically to educate in addition to provide the evidence. So we do educate as well on the terms used and the meaning of actually health economic evaluation.
Okay. Thank you, Olga, for stepping in as fourth panelist. That's really interesting to hear. We can probably follow up on a few of those points later. I'm going to go to Li Yang now and ask the same question, and maybe ask it in the same way I asked Olga in terms of what's the general health economic literacy of the decision makers in China with respect to the work that we do in genomics as health economists. You know, do you find it difficult to have those conversations or not?
I'm not sure. I think there are some key methodology challenges because when we conduct the economic evaluation modeling, there are many choice of the model, such as in the field of cancer, micro simulation and discrete event simulation, or partition survival model or traditional Markov model. So we need to compare different of those kind of models based on limited data availability. So we need to balance between the model accuracy and the data availability. And I'm not sure those kind of economic evaluation literature would provide some kind of evidence for the decision making. As I know, in China, we often will write some very brief policy brief. Those kind of policy brief maybe would help the decision maker to do more policy making based on the evidence.
Thank you, Li Yang. Brock, I'll come to you and maybe ask, I guess, a slightly more focused question, and to ask you to think about Illumina specifically, and the same question really. I mean, you obviously there's yourself and several other health economists there. When you're having those conversations at sort of a strategic level, is there an understanding of the complexities of the work that's required? Are those difficult conversations within Illumina?
I don't know that they might even be more difficult outside than inside. I think maybe it's a little easier to do the education internally that's been needed over the last couple of years to kind of share with people what we think is the type of evidence we need to invest in, you know, ultimately to you know, to show clinical benefit and economic benefit that, you know, that payers and decision makers want to see. You know, that's taken some time, but maybe it's just because we have a more direct, you know, we can repeat it over and over again at every meeting, and that's a little bit easier. I think we perhaps find it, you know, the issue that was, you know, Scott and Leanne brought up in terms of education. If we only get to talk to a particular decision maker, a payer medical director, somebody, you know, once or twice a year, or maybe just have one shot at it, you know, that sort of education is really imperative. I think the literacy around health economics is, you know, depending on the market, not in the US, but, you know, in other markets is of course there. The education around the challenges with, you know, health economic evaluation of genomics is not there, right? And that's where it comes in, is kind of understanding those nuances, why you may not see the data the way you're used to seeing the data, at least now, and what can we do about that? And then the other thing I think we can do, and you and I, James and others have talked about this, is we see there's individual clinical applications that come down the road, right? For whatever application, but we also see a lot of national programs springing up, like the 100,000 Genomes Project, maybe first in the UK, but now we see many of these. And so I think that education about how those should be set up with health economics in mind, so that the right data, or at least, trying to get towards the direction of the right data, is integrated early on in setting up those programs is really imperative. It's taking it upstream the same way you were sort of within a company, you might want to take it upstream within a national program. The further we can take that upstream, so that we're collecting high quality data that can be used for evaluation downstream is I think a critical part of what can be done globally.
Okay, so there's clearly a gap there to be filled if someone wants to write a paper for I don't know, New England Journal of Medicine or the BMJ, educating people on the challenges we face. So I'll leave that to the audience to get together and write that one. I'm conscious of the time. I have plenty more questions, but I'm going to just ask one more and then open things up to the chat. And the question is this: so as well as obviously we produce evidence to inform implementation decisions as health economists, but we probably have a role to play in decision making as well, related to genomic medicine and genomic testing. And there are some institutions, one I can think of is the GA4GH, that doesn't really explicitly consider health economics in the decision making process. And the question is, which are the key global or national institutions or decision makers where the health economic voice really needs to be heard, where we need to have a seat at the table as health economists, and how can we possibly do that? And I guess we can open this to the audience after we've been to the panelists, if they have institutions in their jurisdictions that they want to speak to. But how can we have a more impactful seat at the table as health economists related to decision making? Or should we, I guess, is a more fundamental question. I'll go to Scott first on that question.
I wish there was such a forum globally. The World Health Organization would be an ideal convener, and they already do this for vaccines. Whenever there's a possibility of considering new vaccines, the WHO convenes a work group to prepare a vaccine value profile, international group that addresses all the different criteria. And it would be great if WHO had a similar interest in genomics.
It would. I think it's hard to disagree with that. I don't know how we make that happen, but all ideas are gratefully received. Li Yang or Brock, really, I don't know if you want to speak to that question. How can we ensure that health economists, if they ought to, have a seat at these tables? Is it the WHO, or should we be trying to get that seat at the table at other organizations?
Yeah, I think in China there are two kinds of decision makers. The one is the National Insurance Bureau, who are responsible for the decision making related to reimbursement of genomic medicine. I think in the past recent years, and the National Insurance Bureau, they many health economics were involved the decision making process for the national insurance drug list. And another decision maker, I think, is a National Health Commission in China, who are responsible of the public health program. I think in this domain, maybe mainly of the decision making are lacks of HTA evidence. So firstly, I could say, yeah, we need to educate the decision maker, and then we need to generate and produce the high quality HTA evidence around the public health programs, such as the cancer screening program. Yeah, so we need to produce a high quality evidence, and so we could persuade, or we could private the evidence for the decision making about those kind of public health program.
Thank you, Li Yang. It's very interesting from outside of China to get a sort of a more detailed understanding of how these decisions are made. So that's really helpful to know. Brock, very quickly before I go to the audience, any comments to speak to that question?
I was thinking about it two ways. One was educating. It's maybe going back to the last question a little bit, but educating the groups that are already doing this, the HTA bodies in particular, on the genomics challenges, right? Because there are already these groups that do understand health economics, but they're not doing it with genomics yet, or only very rarely doing it with genomics interventions. That's one aspect. And then you brought up G4GH, but I also think about the clinical societies like ACMG. It's the American College of Medical Genetics, the ESHG, even ASCO, NCCN, ESMO. The clinical societies, I find, historically haven't focused as much on this, but I see maybe more interest. I'll just give one example, or not an actual example, but more of a generalization of some things I see. Sometimes we'll see clinical guidelines or clinical position papers that are written from societies that will say things like, this looks like a good technology, or this technology is shown to have benefit for this region, but it costs more, period, right? And so I think education about those kinds of statements is important, right? And ultimately getting them to actually think about the cost of the health economic literature and summarize that as well, so that it's not just but it costs more, it's something more something more comprehensive, and including health economists. I've seen the ACMG poking around in that a little bit. I think some of the others have as well, but that's another angle where it's actually trying to influence the clinical societies to say something, to pull in that expertise when they're thinking about guidelines as well.
Great points. Thanks, Brock. Okay, I'm going to stop talking now, and I'd really like to get some questions from the audience. There are topics we haven't covered, and now is your chance to push them to the top of the conversation. So if anyone has any questions, please unmute, and if you're happy to do so, show yourself on screen, and please ask away. Do we have any volunteers?
Hi, everyone.
Hi.
Hi, I'm Tian Jiao. Nice to meet you guys. Thank you so much for sharing, for your highlight, for your opinions. I got some questions that I would like to ask. The first question is to Li Yang. If my memory is right, so you mentioned that there is one drug that's listed in the Chinese national scheme. It has the lowest price in the world. Can I ask which is the drug? Can you hear me, Li Yang?
I can see that Li Yang is frozen.
Okay.
Possibly we've lost her briefly.
Yeah,
perhaps we
probably
can
lost her.
part that question for a minute, and I think you have a second question.
Sure. My second question is to Scott and Brock. If my understanding right, you mentioned that health economics and HTA doesn't play an important role in US. Is that because US is not using universal health system?
Because
Yep.
Sorry, Li Yang, go ahead.
Could you repeat? Yeah, could you repeat again, because the disconnect of the internet?
Yeah, sure, no problem. So if my memory is right, you just mentioned there is a drug that listed in Chinese national scheme, so things. Is that, can I ask, has the lowest price in the world? Can I ask which is the drug?
DAA for HCV, direct
okay.
active antivirus.
So it's DAA for,
for
HCV,
hepatitis C viral.
Oh, okay. Okay, I'm gonna have a look. Thank you so much. Just interesting about it. So to the second question is Scott and Brooke. So you've mentioned that health genomics and HTA doesn't play an important role in US healthcare system. Is that because US is not using universal health care system? Is that the reason? Do you think so?
The United States doesn't have the record low price for drugs. We often have the record high price for pharmaceutical products.
Okay.
So, polar opposite from China. And I suspect that's not unrelated to the relatively minor role of cost effectiveness analysis in decision making in the United States. I think I'll leave it there.
Yeah, cool. Thank you. Do you have any thoughts, bro?
Not really anything to add. Yeah.
You're great. You're great about that.
I think that's just the way it's developed. I mean, there's some, you know, in terms of kind of the public discourse about this, I think historically there's been, you know, discussion back and forth around whether, you know, having cost effectiveness equates to, you know, not providing the best care, right? As opposed to using finite resources wisely. So I think the public discourse has kind of sometimes been there, and therefore it's kept, you know, it's kept the country away from cost effectiveness officially.
Yeah, I think back to Obamacare. So he thought about that to have the universal healthcare. Is that right?
Yeah, the way Obamacare was implemented was to, rather than universal healthcare per se, you know, as a single payer, it was to allow the public, you know, allow the commercial markets to put in, you know, individual plans, and then, you know, try to mandate that most patients have access to engage in either having coverage through commercial payer, you know, through their employer, or through those individual markets, or by expanding state Medicaid, those programs, you know, for lower income. It hasn't achieved universal health care, but it's, you know, improved in terms of the proportion of people in the US that don't have insurance. But it wasn't put into place as a single payer, you know, system.
Yeah, okay, cool, thank you. My last question is to everyone. So for measuring health outcomes of genetic testing, traditionally in cost utility analysis, we use qualities, right? But for genetics, do you think it's still applicable and feasible? And personal utility has been mentioned quite a lot in many papers for genetic testing. Like, do you have any source in measuring health outcomes? Thank you for the noise outside.
Okay. Does anybody want to comment on that? I mean, there's plenty that could be said, I'm sure.
I couldn't hear the question.
Sorry, simply my question is about quality and personal utility.
Well, I'm a big fan of personal utility. I
know, I have read a lot of paper from you.
But how to persuade payers to value that is the challenge.
Do you have any source about that? This is my question.
Well, Brock, you work with the payers, I don't.
Yeah, I don't know that there's I might actually, yeah, I'm gonna phone a friend. I'll try to answer it, but I'll phone James and Dee Dee here and put them on the spot as hosts. Some of the work, you know, I know you're doing on this in this area. I don't know that I'm aware of a kind of success story in that area yet. I've started to see those, you know, personal utility and, you know, efforts, you know, methodologies to quantify personal utility in terms of DCE methodology and that sort of thing being obviously published and starting to be cited a bit. To me, the challenge has been, how do we work from that being, if we thought about an HTA framework, which barely exists for genomics, but if we thought about HTA frameworks existing for genomics, how do we take it from being kind of a supplemental thing that you can submit to being, a core, potentially core aspect to the submission? So I still see it as useful, and it's kind of an alternative methodology to generate this important data. But I don't know that payers are probably at that place of having it be primary data yet. It's probably still supplemental, but that's maybe, I don't have that much experience in it, so I'd be interested to hear anybody else speak to that.
Yeah, I mean, I guess just one quick point from me on that is that I always feel like that there's a step in the middle that we haven't done yet. Like, I think there's a lot of us here who could be quite easily persuaded that personal utility should inform these decisions in some shape or form. But I think until we can show that we're making bad decisions or suboptimal decisions by not considering personal utility, it's going to be quite difficult to persuade health technology assessment agencies that it's something important to consider. And I would also say that it's a real shame that Sarah couldn't be with us today, because I know in Australia, I think probably they're more advanced than in a lot of other jurisdictions as to consideration of the broader value framework for genomic testing. And I know Sarah has published a little bit on that, so I'd have a look at her work on that. Maybe we can move on. I can see Zanfina has her hand up with a question. Bonnie, you have your hand up. Is that a question, or is that on this point?
This is on this point, but very briefly.
To you first.
So I know, so I've got a little bit of experience with MSAC in Australia as well. So the Medical Services Advisory Committee has kind of, over the course of considering several diagnostic tests for genomic medicine, ended up making their decisions on the basis of cost per diagnostic yield, more so than cost per quality, simply because there's still very little evidence where they can kind of connect the whole exome sequencing or something to a change in treatment that results in a quality gain. And this question is actually more to you, James. Like, what about NICE? Have they really kind of gone down the whole doing cost analysis, HTA, cost effectiveness analysis of diagnostic tests in the UK, and made a decision based on a cost per quality?
We're certainly not as advanced in the UK in terms of thinking on this subject. I mean, I think Australia is really leading the way in terms of thinking out of the box a little bit more in terms of what feeds into these decisions. I think there are, I haven't looked for a little while, but I believe there are decisions made by the NICE diagnostics, I forget the acronym, the diagnostics evidence, you can make up your own acronym. They do have some decisions they've made where they've referred to quality evidence, but I think for the large part they haven't. And I think if there is a sort of methodological challenge that is the primary focus, I'd suggest it's more in the context of diagnostic, it's that separation or not that Brock referred to earlier, in terms of whether you're evaluating the treatment or the treatment and the test, and how that can be captured in decision making. And I don't think we've really gone much beyond that in terms of, well, hey, can we capture personal utility benefits using a DCE and feed them into the equation? That I don't think we're going to get there just yet in the UK. But that's just me. Looking at time, Zanfina, you had your hand up. I think we have time for one more question if you'd like to ask.
Yeah, just to sort of summarize, James, because we spoke about the challenges and success stories, but also we have to think about harmonizing these methods into genomics. And Liang actually mentioned as well that some of health economics or decision modeling is not the only tool to make that the decision makers make decisions. So it's budget impact analysis, the cost of the drug, but also in some countries, especially in European Union, ethical consideration and jurisdictional consideration play a key key role in genomics and health economics. So it's a question for panel, just to sort of summarize. How do you see this sort of playing in a long term and in a future? Can we sort of harmonize these approaches to the countries who are willing to do such harmonization with regards to genomics and health economics?
So who's going to be brave enough to have a go at that first?
I'd like to hope so, but I don't know. It's a great question. I don't even know, even if we look at individual decision makers now, that there's it's almost stepwise, I think, right? And we see different frameworks or different attempts at frameworks, even continuing in individual decision makers, much less harmonization. But I think it's a worthwhile goal. That's not really a great answer, but I don't know. Others, Scott, what do you? Nope.
I have some thoughts about. There are some value-based decision making methods, which means the value include many kind of defeat, such as the cost effectiveness and the price, the budget impact, and the ethic issue. So if we could give the weights for each field, so we could harmonize those kind of together.
Okay, so you sort of suggesting to have like health economics, budget impact, ethics, and jurisdiction, and then we give a weight out of 100, and based on that, yeah, that's a great way of sort of putting. Thank you, Leanne.
Thank you.
Okay. I think, well, we're a few minutes over, so I'm going to suggest that we stop here. We're going to have a short break. But before we do, I'd just like to say a big thank you to Li Yang, to Brock Schroeder, and to Scott Gross for answering or carefully not answering in some cases some of the questions, but for very good reasons. Thank you for giving up your time and for contributing. This wouldn't have happened without all her input. So just to extend our thanks for that. I think it's been an interesting discussion, and I think I will be going back to the recording a few times just to think about some things again. So we're going to take a short break. We're about 5 minutes over, but I think that's okay. We're going to stop for 5 minutes so you can all get a drink, just step away from the computer. And then when we come back, we're going to go to the second, slightly shorter bit of the symposium, which is the Early Career Researcher and LMIC workshop part. So please disappear, take a step away for a few minutes, and in 5 minutes time, so 25 minutes to the hour, we'll start off with the workshop.